Thank you very much for the kind introduction. It's a pleasure to be here, and I'm going to talk about empagliflozin with something different called the LACA, or the liver alpha cell axis. So we know that SGLT2, DPP4, metformins have been there for years and years. So please raise your hands if you have used all the three together in a patient. I think it will be easier to ask who has not used it together. So all of us have used it together. And if you see, this is a very common concept in Western countries. You have a common, which is a common area where people use all the facilities commonly. And then, this is a very old concept. It is there in today's societies also. And there are individual families living around the common, which have got some individuality, but they use the common facilities. So similarly, if you look at SGLT2, DPP4, and metformin, there are some features common to all of them. Let me try to get the pointer, sorry. There are some features common to all of them, and those features are, they're all weight friendly, they don't have hypoglycemia, they have good A1C control. Then there are some features unique to SGLT2. They cause weight loss, they have cardiorenal benefits, they cause urogenital infections, they cause ketosis. There are some features common to DPP4, mainly good glucose control, and of course avoiding pancreatitis risk. There are some good features of metformin. It's got good glucose control, no hypoglycemia, but GI intolerance and B12 deficiency. But if you look at glucagon, and that people don't look at glucagon always, all three have very different actions on glucagon. SGLT2 increases glucagon. Metformin, there are studies which show that it may raise or decrease glucagon. And DPP4 will lower glucagon. And why are we talking about glucagon? Now this is a picture, sorry, I generated this on AI of the islets of Langerhans, on which Tom and Jerry are playing. And Tom is glucagon and Jerry is insulin. And if you look at Tom and Jerry cartoons, always the Tom gets a bad name, Tom always loses. But Tom wasn't always bad. Tom got a bad name very early on. And this is a picture of Tom on his first day in school. On the first day itself, the teacher got a bad impression. What happened? That whole year is gone. Similarly, glucagon was actually described as a villain. So glucagon had a very inauspicious start. It was discovered as an impurity in early preparations of insulin, and it was called a toxic fraction, causing a rise in blood glucose levels and even death. Then in 1973, Robert Unger and Leloard, they sort of hypothesized that diabetes is due to two diseases. One is insulin lack and glucagon excess. But glucagon kept on getting a bad name. Now glucagon is a 29 amino acid peptide produced by the alpha cells, and it depends on where glucagon, the precursor is. Some precursors convert into GLP-1, some convert it into glucagon. Now it's important that we don't know even today whether it is glucagon or insulin which keeps the blood glucose levels in check. But one thing is for sure, when there is low blood glucose levels, the body releases more glucagon. And when there is high blood glucose levels, the body releases more insulin. And within 80 to 100, we really don't know, but many people believe that within the normal range, keeping the glucose in check, glucagon has an important role to play. So let's look at this picture. On your left, you have glucagon agonism. What does glucagon do to the body? Very interestingly, if you just look at weight, glucagon causes weight loss. It destroys amino acids, it destroys lipids, it makes ketones, and it causes beta oxidation, destroys fat. And it also increases brown fat related energy expenditure by increasing brown fat. It can also act on the brain, but the main thing is it acts on the liver, causes lipid beta oxidation, and it destroys fat. The other corollary of that is that if you antagonize glucagon, if you become an enemy of the glucagon, it may control the sugar, but it is going to increase the liver fat. So that brings us to the liver alpha cell axis, because you have liver and you have the alpha cell making glucagon, or the LACA, which is a very important concept to understand, because it also is one of the theories to explain why you have type 2 diabetes and MASLT. So let's look at metformin. Metformin, by bringing down the fasting glucose, it can increase glucagon, and that's why people on metformin don't get hypoglycemia. Metformin can also counteract the catabolic effect of glucagon, and metformin therefore can also induce glucagon secretion to some extent. So metformin has a very complex effect, but largely it allows glucagon to come in when there is hypoglycemia and therefore increases it. DPP-4s reduce postprandial glucagon, but remember, they actually act like a software for the beta cell and alpha cell. When the sugar is low, they can increase glucagon. When the sugar is high, they can suppress it. But overall, when the sugar is high, like after a meal, they suppress it. What is very interesting is SGLT2. Now, SGLT2 has two effects by which it increases glucagon. One is the indirect effect by causing glycosuria, it stimulates glucagon, and second is a direct effect. The direct effect of inhibition on SGLT2 on pancreatic alpha cells. The other thing is, if you remember, that now there are SGLT2 receptors on the alpha cell. And if you block them, what happens? If you block an SGLT2 receptor on the alpha cells, whenever there is, say, hyperglycemia outside, because of the blockade, the alpha cell cannot sense glucose. So the alpha cells think there is hypoglycemia. So therefore, it can make glucagon, because you are blocking the SGLT2 within the alpha cell. Now this brings us to the very interesting liver alpha cell axis. According to this axis theory is that the liver, there are a lot of amino acids, and the amino acids act on the pancreas, the alpha cells, to make glucagon, and glucagon dissipates the amino acids and the cycle is complete. But what if the amino acid pathway is blocked? Only the amino acid pathway, which means that because the amino acids are not destroyed, there are lots and lots of these amino acids. Here there are less amino acids. Here there are lots and lots of these amino acids. They keep on stimulating glucagon. This glucagon keeps on releasing glucose, but the body can't stop making glucagon because the amino acid pathway is actually blocked. It also leads to fatty liver, because the fatty liver, glucagon cannot act to destroy the fat also. So it also causes fatty liver. So you have amino acids not destroyed, you have the glucose production by the liver continuous, and you have fatty liver because the glucagon fatty acid pathway is also blocked. So that is a theory of the liver alpha cell axis, or LACA. If you look at it, none of these agents, DPP-4 can reduce glucagon, metformin can increase glucagon, but metformin has a GLP-1-like effect, so it actually eventually brings it down. But the only drug that can favorably harness glucagon for the benefit of the liver is SGLT2. How does it do that? Number one, it reduces the glucose load. Second, it increases the glucagon level and that dissipates the liver fat. Why are we talking about all this? And of course, none of these cause hypoglycemia. And there is this paper, we are talking about this because recently, as maybe a week ago, the US FDA has approved injection semaglutide 2.4 for the treatment of fatty liver disease. And if you look at mast cell as a disease, and if you look at which is the other anti-diabetes drug that can help semaglutide, the answer is only empagliflozin or dapagliflozin or whichever gliflozin you want to. But empagliflozin, what is fascinating is there is an Indian study from Medanta Hospital. It is called the ELIFT trial. It is the only Indian study which was done and which showed that in people with diabetes, it can reduce, empagliflozin can reduce the liver fat and improve the ALT levels in Indian people with type 2 diabetes and mast cell, and they did MRIs and they showed that. So in other words, empagliflozin, by throwing out glucose through the urine, reduces the overall glucose levels in the body. So when there is reduced glucose, the glucose is not converted by the liver into fat by de novo lipogenesis, and whatever fat is available in the liver, that is dissipated by the action of hyperglucagonism due to SGLT2. And that is how a drug like empagliflozin, or for that matter dapagliflozin, or for that matter canagliflozin, can all reduce liver fat and can be a useful adjunct in type 2 diabetes and mast cell. And it's very important that this role of empagliflozin and glucagon is recognized as a therapeutic benefit in today's world. Because you are going to have survodutide. You know, survodutide is about to be the next to be probably approved by the US FDA. It's not been approved yet, but it's one of the most promising agents for treatment of fatty liver disease because it also targets glucagon. It's a glucagon agonist. Retatrutide is another drug which is a GLP, GIP and glucagon agonist. So glucagon agonism is going to be harnessed for obesity, for type 2 diabetes paradoxically, and for mast cells. So understanding a molecule that can use glucagon in the right way is important. And why are we bothered about cardiovascular outcome in mast cells? It's important to remember that people with mast cells may progress to MASH, they may progress to cirrhosis, they may progress to hepatocellular carcinoma, but the most common cause of death in patients with mast cells is cardiovascular disease and cardiovascular death. And among all the SGLT2s, whether you take dapagliflozin, empagliflozin, canagliflozin, only one agent has been shown to reduce cardiovascular death. There are many agents which may reduce MACE, 3-point MACE, that's a different matter. But a statistically significant hierarchical testing proved reduction in cardiovascular death. To date, only empagliflozin in the EMPA-REG trial has been shown to reduce cardiovascular death, and that's because of its hemodynamic effect, such as reduction in plasma volume and the direct effects on the heart. So before I show you the take-home points, I want to talk about all of you to rethink glucagon. Glucagon has been an enemy. It's not a friend. It is a partner, a strategic partner to be used in the right way in a multilateral world, which is the world of the body. I'm sure you know what I'm talking about. You have the pancreas, you have the heart, you have the liver, and it's a very multilateral world. And glucagon, used the right way, can actually be of therapeutic benefit. So friends, there is good rationale for the SGLT2, DPP4 and metformin combination. But among them, the SGLT2 stands out. Yesterday or day before, the UK regulatory authority, NICE, has actually approved SGLT2 as a first line for management of type 2 diabetes. And they said metformin is not the first line. SGLT2, especially in cardiovascular disease with diabetes and in chronic heart failure, today SGLT2 is a first line therapy according to the UK regulator. And I think we need to stand up and take notice. The glucose control, weight benefits and cardiorenal protection has to be looked at. And you can look at, if you look at the 3-drug combination, it's a pretty good way to get all the benefits. And if you see, if you use it early as a single tablet, not much titration is needed. Patient's initial HbA1c is 8.5. You give a triple-drug combination, the value stays down. So friends, glucagon is like Tom and insulin is like Jerry. But if you think of both of them as the two hormones playing on the landscape of the pancreas, you now remember, we'll have to reimagine glucagon as a new player, a beneficial player, may reduce NAFLD, may cause weight loss, and if used rightly, can be harnessed for betterment of care of patients in future. Thank you for listening to me. It's a pleasure talking to you.